Okay, so this video is on Chaney. Chaney conducted a study. It should be Chaney et al. On there. So it's Chaney, Clements, Lalande, Bulsara, and Watt in 2004 conducted a study where they were trialling a new asthma spacer to see if they could improve compliance in children. So it was a bit of a pilot study. So it is the contemporary study in the developmental area. Your key theme is external influences on children's behaviour. The area is developmental, and this is your contemporary study, like I say. So by the end of this video, we should be able to define a couple of things, so operant conditioning and something known as the law of effect. We should be able to explain why this study was conducted. We should be able to describe some of the details of the study, and again, we'll evaluate it a little bit, but we'll not go into tons of detail because we'll do that in lesson. Okay, so some of the background theories that we need to know about. So a theory on which this study is based is operant conditioning. So operant conditioning is a form of associative learning. So you've got associations and connections that are formed between a stimuli and a response that didn't occur before learning. So in other words, you learn through the consequences of behavioural responses. So there's some sort of stimuli, so there's something in your environment which will then cause a response, and the consequence of that response will determine whether you choose to perform that behaviour again. Okay, so it's like we've got that little picture of the rat down there. We'll press lever for food. So if you rig a contraption so that a rat will press a lever and it knows that it's going to get food, it's going to get a treat, then it's more likely to go back and press it over and over and over again. Okay, so you've trained the behaviour. It's associated the treat with the behaviour. So operant conditioning was first investigated by somebody called Thorndike, who found that any response that led to a desirable consequence was more likely to be repeated, whereas if it led to an undesirable consequence, it was less likely to be repeated. So this idea then became known as the law of effect. So if it's got a positive outcome, you'll repeat it. If it's got a negative or a less desirable, undesirable consequence, then it's less likely to be repeated. And then this was developed later on by B.F. Skinner. So he was quite a famous behaviourist who tried to do quite a lot of bits of research with animals and tried to explain how many different behaviours are acquired or are learned. So you've got law of effect there. So you've got two sorts of rewards in operant conditioning. So you've got positive reinforcement and negative reinforcement. So positive reinforcement is when something good happens. So you get points, or you get a sweet, or you get praise from your teacher or your parent. And then you've got negative reinforcement, so that's when nothing bad happens. So it's not that you are trying to avoid a punishment, because that's something completely different. It is that you are trying to perform a certain behaviour because it will avoid a negative consequence. So like it says there, if you know you brush your teeth daily, then that is going to mean that you avoid having things like fillings. Or if you know that your mum is going to nag you if your room's dirty, you keep your room clean and tidy, because it's then going to avoid her nagging you. So punishment is a completely different thing. So punishment will lead to the behaviour not being repeated, whereas positive and negative reinforcement lead to it being repeated. Okay. So in your background box, all this needs to be going in there. So asthma is a condition which we'll talk about in a second, but it can be quite a mild disease, or it can be quite a major disease. So particularly in children who don't especially enjoy the treatment for asthma, there is a potential of fatalities. So treatment of children, little quote there, treatment of children has been recognised as a major unmet need in the management of asthma. So in other words, the treatments that are available for children, a lot of children don't like using them. So unless we can find some way around this, we're not meeting their needs. We're not able to manage their condition. So asthma mortality rates have declined since the mid-90s, but there are still preventable deaths. So they've tried lots of different things over the years. So there's been education programs and about why you should use the treatment programs that you've been given, but they've not been shown to be very effective. In Australia, so there's some statistics here. In Australia, 1 in 4 children have asthma. Asthma attacks are the second most common of paediatric hospital admissions. So for children, the second most common reason that they get admitted to hospital is because of asthma, and it's also a major cause of children missing school. Okay, so even though they've tried all these different strategies and things, they're still finding that children don't want to sort of adhere to these prescribed techniques and frequencies for the amount of times they're meant to use their inhalers, and it can cause a major problem for children with asthma. And if there is some sort of behaviour modification that we could use, then this could be used in helping them, but also by like clinical psychologists and health practitioners, people in medicine, in trying to get people in general to adhere more to their training programs, their treatment programs. Sorry. Okay, so yes, you've got a little bit of a diagram. So in somebody who's asthmatic, you can see there that the passage for air to pass through is more constricted in somebody with asthma than somebody without asthma. Okay, so it means that we essentially don't have normal airways and therefore cannot take in as much air. And there may also be things like swelling of muscles around the airways, mucus present in the airways, and then that again will limit the amount of successful intake of air that people can manage to pass around their body. Okay. So poor compliance. So compliance here is basically meaning they're adhering to the treatment, they're taking the medicine when they're supposed to. With prophylactic or preventative medication is a major cause of apparent treatment failure. So prophylactic medication is medication which you are given to prevent them from experiencing symptoms. So a lot of children are given these inhalers to use, and they're supposed to use them so many times a day, and that will prevent them from having a serious asthma attack later on. So it might be you have to use it 4 times a day, and if you keep doing that every day, then you won't have a severe asthma attack. Compliance is notoriously low in all age groups. So it's about 30 to 70% in children. And there's a couple of reasons for this. So in young children particularly, you could say that it's poor techniques. So when children are actually using the treatments, they're not doing it properly, and therefore they are not getting the benefits out of them that they need to get. And non-compliance of caregivers who often say that the process is stressful. So if your child is like kicking and screaming and crying and saying they don't want to do it, or they won't do it, they won't even try, then parents and caregivers are finding it stressful to try and get them to do it, so they just give up. Okay. So this is kind of like what a spacer looks like in the picture. So a spacer, so you've got your inhaler just here on the end, and then you've got a face mask, and then you've got the spacer in the middle. So most adults will just have this inhaler if they've got asthma, but the child inhales the drug through the spacer using tidal breathing with a face mask or with a mouthpiece, depending on their age. So the face mask is for children under 3, the mouthpiece is 3 to 5. So actually this one has got a face mask, but you can see that this child has also got a little mouthpiece just there, so she must be over age 3. So there's different size spacers. They look fairly similar, and obviously some adults, depending on their condition, may still have to use a spacer, and they have a larger one, but the child ones are just smaller. Now you can see that they're just like this big contraptions. Children, they're quite unappealing, and they tend to, if they don't like taking part, like I say, when the carers give up because they are, crying, upset, screaming. A lot of people used to believe that the longer that they were like crying, screaming, those behaviours were happening, that meant that they would increase drug inhalation, because you're sort of gasping in, aren't you, as you're crying and when you're deathly upset as a child. But it's actually the opposite. So while the child is crying or in distress, they're actually taking in less air rather than more, less of the medicine. Okay. So pediatric compliance rates for pressurized meter dose inhalers is about 39 to 67%. So you can see with all these different types of inhalers, it's quite a low adherence rate. So very few people actually use the treatment programs that they're given. Adherence does not improve with the severity of illness, so you would think that the more severely ill somebody is, the worse their asthma is, the more likely they might be to actually take the drug that is prescribed to them, but that's not true. And there's different reasons for not complying, for not using the inhalers that they're given. But research, so what suggested that if you can have this interplay between adherence considerations and aerosol output, it would improve adherence in young asthmatics. So if you can think about the reasons why children don't want to adhere to it, don't want to use the spacers, and then be thinking about how much they need it, then there needs to be this improvement in the amount of times that they use them, in their use of the treatments that they give them. Okay. So aim of the research. So the aim of the research was to show that using a novel spacer device, so instead of the traditional spacer, they made a novel one, a new one, and it was called the Funhaler. It can provide positive reinforcement, which would lead to improved adherence. Okay, so they developed this Funhaler. and it incorporated positive outcomes. So positive things like there was toys on it. You can see a bit of a diagram there. So it had the pressurized inhaler, the spacer, and then on top of that there was like a whistle. So as they were breathing out, the air would go through into the toy ball where things might like bounce around. It's a bit more visually appealing, and then air would come out of a whistle. Now, this whistle and things were isolated from the main circuit by a valve. So here you have a valve. So a valve is something that controls the flow of air or water or whatever it is. So this valve allowed, when they were breathing out, for the air to go through, but it didn't allow air to come in from up here, because otherwise that would contaminate the medicine that they're trying to breathe in, if that makes sense. Okay, so it just made sure that it didn't compromise the delivery of the drug. Okay, so your research method. This was a field experiment, so it was conducted in Australia, and it was done in the participants' own homes. So it's a field experiment. It was a repeated measures design. So they were looking at whether the behaviour, which is adherence to their treatment programme, was better or worse when they were using the traditional spacer compared to when they were using the Funhaler. Okay, so all the children participated in both conditions, the traditional spacer and the Funhaler. Okay, so the IVs were use of the standard small volume spacer, which was called the Breathatek, and then use of the Funhaler. And the DV was the amount of adherence to the prescribed medical regime. So whether they were using the treatment that they had been told to use. Okay, so sample. So you had 32 Australian children, 22 males, 10 females. They ranged from 1.5 to 6 years, and the mean age was 3.2 years. And the mean time that they'd had asthma for was 2.2 years. Okay, so they're factoring that in as well, because remember it said that you would imagine that the longer you've had it for, or the more severe it is, the more you would adhere to it. Or maybe if you've just got asthma, perhaps you don't like it. So they did think about the mean amount of time that they'd had it for, and it was quite a while. Now, all of these children were currently receiving regular treatment using the prescribed drugs delivered by the pressurised inhaler and the usual spacer, the Breathatek spacer. It was an opportunity sample, so 7 local paediatricians. So these are like general practitioner clinics, and most of them focused on children. So a paediatrician is a child doctor. In a region of Australia, all within a radius of 51 kilometres from one another. So they were used to sort of collect these children that were going to be used to recruit them. So the parents provided informed consent, and the parents also participated in the study, so they had to use some self-report measures, so questionnaires, taking part in phone interviews, and the parents did this to tell them about the children's behaviour. Alright, so the parents were initially contacted by the study coordinator over the phone. And then they, if they said they were interested in taking part in the study, visited them at home where they got written informed consent. So they weren't mentioning the Funhaler at this point, Now, the reason that they weren't mentioning the Funhaler at this point was because they didn't want sort of like any bias to be present. So they were approached by the researcher at home initially before the Funhaler was mentioned, and they were interviewed on their existing attitudes towards the current asthma device. So they had fixed choice questions on there. The validity of this questionnaire was checked as well. So it was ascertaining like how much the child would use it, whether they adhered to the regime, how the child felt about it, all these kinds of things. So the questionnaire was completed without the Funhaler. The Funhaler wasn't shown to them, it wasn't described to them, because they wanted to minimise recruitment effects. So they didn't want it to sort of bias whether people then decided to take part in the study or not. Okay. So then they are given the Funhaler for 2 weeks, and they were instructed that it was only to be used with adult supervision. And they were reporting then over the phone on an ad hoc basis to take snapshots of whether they had used the Funhaler on the previous day. So parents would occasionally get a phone call to say, did the child have their medication yesterday? So the parents would report in this way. They were also visited once more at the end of the 2-week trial by the researcher, where the parents were interviewed, and they also filled in a matched questionnaire after the use of the Funhaler. So they filled one in after using the breath attack, and they filled one in after using the Funhaler. Okay, so this is kind of like what the spacer looked like. So it was a low volume spacer chamber that was developed with optimal delivery characteristics, is how they would define it. So it was the pressurized inhaler, the spacer with the mask on. So it had the mask for the preschool children, and it had these compartments on to make it resemble a toy. So you can see there in the sort of like green ball, it's got like a spinner in it, so it's like visually attractive, and then the red bit is the whistle, and these parts were sort of visually attractive, draws the attention, so you can see like when she's using it, she's looking directly at the sort of the spinner, and it makes it easier and it makes it more pleasant to use. So it was trying to distract the attention of the children from the drug delivery itself, and provide them with this means of reinforcing using the effective technique. So if they're using the technique properly, then they'll find that the spinner goes round, the whistle makes the sound. So it makes it appealing to the children by having these incentives, by making sure that they are getting sufficient delivery of their medicine, and tries to link optimal function of the toys to the deeper breathing patterns. So in order for this medicine to work, they need to use deep breathing patterns. So the deeper the breathing pattern they use, then the better the toys, the attachments work. So it encourages them to use the correct technique. And it also anticipates that kids might get bored of using the spinner all the time and the whistle all the time. So they allowed this modular structure to it, which meant that the incentives could be replaced with different toys. So the ball and the whistle sort of came off and could be replaced by other toys within the same range if that was needed. Okay, so the data collected in the questionnaires was about how easy each device was to use. It was about the compliance of the parents and children. So did the children take their medicine? Did they kick up a fuss about it? Did the parents encourage them to do so, or did they give up as well? And the treatment attitudes. Okay, so like I said earlier on, so it was self-reinforcing. So as they were using it, they were becoming rewarded with it. So it made them appealing through the design. So it isolates the toys while avoiding contamination with the drug delivery. So like I said, it was through a separate circuit on a different valve. It ensured that they aren't taking in air through the toy circuit, so it's not coming in through the whistle. They linked the optimal function of the toys with the deep breathing. So like I said, the toys work better if they breathed in a deeper way, which meant that they had to do it in this way if they wanted the toys to work at their best. And that's what they needed to do for the medicine. And it had that modular format, so they could have swapped the spinner and swapped the whistle if they were getting bored of it. Okay, so there we go. It's kind of what it looked like from the side. So you've got the mask, the spacer, the inhaler, the spinner, and the whistle. Okay, so they avoided this becoming contaminated with drug delivery. So where the sort of yellow arrow begins, the one going round, there would have been a valve to prevent the sort of air from going both ways. Should move that. It ensures sufficient resistance to minimise inspired air through the toy circuit, so there wasn't air coming in. Like I say, I tried to get them to breathe deeply, so they press this and then they breathe in and out through here, and if they breathe deeply they should get the majority of their medicine. Alright, so quantitative results. So they only had 27 responses to both questionnaires. So the end result is going to be out of 27 all the time. So they had 32 children, but 27 participants, 27 children had questionnaires completed, both for the breath attack and for the Funhaler. So they found that 59% of the children, so 16 out of 27, had used their current device on the previous day when they were randomly questioned. So when they randomly rang the parents and said, did they use their inhaler yesterday? Only 59% said yes, but then when they changed to the Funhaler, this figure went up. So then 81% of people used the Funhaler when they randomly called them. There was 30% more of children took the recommended 4 or more cycles per aerosol delivery. So it might be that you sort of pump once and then you breathe in and out deeply, pump again, breathe in and out deeply, and again. So you're meant to do it 4 times basically. So that's the recommended amount, and they found that with the current device, with the Breath-A-Tech, 50% of participants were doing that, and that was significant at the probability level of 2%, compared to 80% with the Funhaler. So the probability level of there's only a 2% chance that what they found is by chance, they are saying that 30% more people used the correct dosage when they were using the Funhaler. Okay. And they also said that when they were using the standard or the small volume spacer, so the Breath-A-Tech, only 3 out of 30 parents said that they were always successful, whereas this then rose massively to 22%, 22 parents, sorry. So 22 parents, 73% with the Funhaler. So there was a massive difference in parents saying that they were always successful in getting the child to take their medicine. Okay. So there was only about 3 children who continued to have problems. So 22 used it, no problems, they got the child to use it every single time. So out of the 27 that are left with the questionnaires, you've got 4 left over. So 3 continued to have problems, but only 3, whereas 1 became more successful over time at using the spacer when it was the Funhaler. So they said that the Funhaler was associated with fewer problems than when using the existing device. So because it was so easy to use, the incidents where the children were like screaming, crying, struggling, didn't want to use it, reduced when they were using the Funhaler, the new device. Okay. Now, of the children's opinions, many of the children, so 13 of the children, said that they expressed fear, dislike, panic when using the Breath-A-Tech, when using the current inhaler. So they didn't like using it. It was not an enjoyable experience for them, very full of discomfort, both parent and child, but the child very much did not enjoy using it. But then when using the Funhaler, this decreased to 0. Okay, so 21 of the children displayed attitudes of pleasure. So it went from most of them, so 13 of them, disliking it, feeling horrible about using it, not enjoying the experience, but then 21 of them actually enjoyed using it. So the children seem to enjoy using it, but you're saying they seemed to enjoy using it, so we don't know if that's really a valid conclusion or not. So how do we know that they enjoyed using it? Did they, if they're self-reporting, if they're saying that they enjoyed using it, then did they say it because they enjoyed using it that day, but did they always enjoy using it? So we're not quite sure on how valid that is. Okay, but your general conclusions, so it improved adherence, so it improved how able parents and children were to stick to these medical regimes that they're given. So improved adherence combined with satisfactory delivery characteristics means the Funhaler may be useful for management of young asthmatics. So when it's saying delivery characteristics were satisfactory, because it's encouraging them to take the deeper breaths that is necessary for them to take in order to ensure they're getting all their medicine, that matched with the fact that they are now happier about using the inhaler in general means that we could use this as a strategy to help manage asthma in young asthmatics. Okay, use of a Funhaler could be translated to improved measures of clinical outcome. So if we are implementing this as a strategy, then medically they should, they should be better off, shouldn't they? Use of functional incentive devices such as the Funhaler may improve the health of children. Okay, so we can use the Funhaler, but then this idea might also roll out to other medicines that children have to take, other things that children have to do that they don't particularly enjoy doing when it comes to their health, but they have to do in order to maintain a good health. We could use this theory elsewhere. But more research is recommended in the long-term efficacy of this treatment. So it worked for the 2 weeks that this study was done for, but would this work for a long period of time? So even though they had the different component parts that they could change to make sure they didn't get bored, would they still have the same attitude when they were a year older, or 2 years older, or 3 years older? Okay. So have a go at writing the reference. So make sure all your commas and dots and dates and names are all in the right places.